genetic risk, adherence to a healthy lifestyle, and coronary disease. Both genetic and lifestyle factors contribute to individual-level risk of coronary artery disease. The extent to which increased genetic risk can be offset by a healthy lifestyle is unknown. Using a polygenic score of DNA sequence polymorphisms, we quantify genetic risk for coronary artery disease in 3 prospective cohorts. 7,814 participants in the atherosclerosis risk in communities (ARIC) study, 21,222 in the Women's Genome Health Study (WGHS), and 22,389 in the Malmo Diet and Cancer Study (MDCS), and in 4,260 participants in the cross-sectional bioimage study for whom genotype and covariate data were available. We also determined adherence to a healthy lifestyle among participants using a scoring system consisting of 4 factors: no current smoking, no obesity, regular physical activity, and a healthy diet. The results were that the relative risk of incident coronary events was 91% higher among participants at high genetic risk, top quintile of polygenic scores, than among those at low genetic risk, bottom quintile of polygenic scores. A favorable lifestyle, defined as at least 3 of the 4 healthy lifestyle factors, was associated with a substantially lower risk of coronary events than an unfavorable lifestyle, defined as no or only 1 healthy lifestyle factor, regardless of the genetic risk category. Among participants at high genetic risk, a favorable lifestyle was associated with a 46% lower relative risk of coronary events than an unfavorable lifestyle. This finding corresponded to a reduction in the standardized 10-year incidence of coronary events from 10.7% to an unfavorable lifestyle to 5.1% for a favorable lifestyle in ARIC, from 4.6% to 2% in WGHS, and from 8.2% to 5.3% in MDCS. In the bioimage study, a favorable lifestyle was associated with significantly less coronary artery calcification within each genetic risk category. Across 4 studies involving 55,685 participants, genetic and lifestyle factors were independently associated with susceptibility to coronary artery disease. Among participants at high genetic risk, a favorable lifestyle was associated with a nearly 50% lower relative risk of coronary artery disease than was an unfavorable lifestyle.
So we started with a very simple question. If you're at high genetic risk for heart attack, can you overcome that risk by adhering to a healthy lifestyle? We studied this question in over 50,000 participants from several research studies. All these participants were healthy at baseline and then followed over time for risk of heart attack. From the baseline information, we determined an individual's genetic risk by looking at over 50 genes and grouped the 50,000 participants into high genetic risk, intermediate genetic risk, or low genetic risk. We also characterized their lifestyle habits at the baseline and grouped them into an unfavorable lifestyle, intermediate, and favorable lifestyle based on just 4 factors: whether you smoked or not, whether you're obese or not, whether you had a prudent diet, or whether you had regular physical activity. And we looked at the relationship between the genetics and the lifestyle in terms of risk of heart attack. And what we found was that if you're at high genetic risk and unfavorable in terms of your lifestyle, you had about an 11% risk of heart attack over the subsequent 10 years. But if you're high genetic risk and had a favorable lifestyle, your risk of heart attack was only 5% over the 10-year period. This means that a favorable lifestyle can cut the risk of heart attack by more than half among those at high genetic risk. The take-home message from the study is that DNA is not destiny, at least with regards to heart attack, that you actually have control over your risk by being ideal in terms of lifestyle factors. And I think this is a very good public health message that we all can actually reduce our risk by doing these relatively straightforward things like regular physical activity and eating a healthier diet.
Graduation is a memorable time for every college student, but especially so for Megan Johns.
I had a pressure in my chest, and it felt like a stack of books was on my chest resting. And then my left arm was tingling, and it felt heavy.
The day before her graduation ceremony, 21-year-old Megan had a heart attack.
I was vegan, so I didn't eat any meat or dairy. I worked out regularly. School was important to me, so I just stayed healthy, and it just didn't make any sense.
Megan's family didn't have any known risk factors for heart disease, so initially doctors had said her heart attack was caused by birth control pills. After months of questions, dozens of tests, and few answers, Megan came to Cleveland Clinic, where doctors ordered a unique blood test, and the result? A genetic link to heart disease called lipoprotein A.
It is a special type of cholesterol that actually increases the tendency to have heart attack and stroke by making the cholesterol sort of thick and more clot forming.
I was relieved to find out something, to just be able to know and feel confident that I know what's wrong and I can now take care of myself.
The entire Johns family was tested for lipoprotein A, and sure enough, Megan's mom carries the same biomarker. It's something they never knew they carried, but can now control.
I have a predisposition to high cholesterol, and even though I eat healthy, it's always will be elevated unless I take medication to do something about it.
It's an easy thing to do to just know what your risk is, and then if something ever happens, you can listen to your body and know what it's telling you.
At Cleveland Clinic, I'm Erica Foreman.
Well, what we are trying to find out with our study is that whether incorporating genetic risk information lowers bad cholesterol when we are estimating risk of heart attack. And we found that when we gave individuals their genetic risk information in addition to the usual risk factor information, that resulted in nearly a 10 milligram lowering of bad cholesterol at 6 months after disclosure of risk. Interestingly, we found that in the group that got the genetic risk information, we didn't see any significant change in their dietary fat intake or physical activity levels. The main reason for the lowering of the bad cholesterol was these individuals got started on a statin medication more often than individuals that just got conventional risk factor estimates. So one of the goals of this study was to assess whether we can communicate genetic risk to patients. And for that purpose, we used the electronic health record, and within the electronic health record, we had a decision aid, which is a picture that shows risk of heart attack over the next 10 years to the patients, and then what happens if we add genetic risk information, and also what would be the lowering of the risk if they were to start on a statin medication. And then the patient, together with the physician, made a shared decision on whether or not to start a statin medication after they received this information in a pictorial form using this decision aid. What we learned from this study is that if we incorporate genetic risk information into our daily practice when we are estimating risk of coronary heart disease, we can actually cause a lowering of bad cholesterol 6 months after we disclose the risk to the patients. When we estimate risk of heart attack in individuals, we use known risk factors. Examples are smoking, diabetes, bad cholesterol, high blood pressure. and we then bin them into low risk, intermediate risk, or high risk. Generally, we know what to do with individuals that are at low and high risk, but often we are not able to make decisions on those that are at intermediate risk. So having new methods of refining risk in that group of people would really advance patient care and prevent adverse outcomes. We have learned over the last several years many genetic factors that influence susceptibility or risk for common diseases, be that heart attack or diabetes. What this means that we can use some of that information in patient care situations. For example, to motivate individuals to make changes in their lifestyle, be that diet or physical activity, or physicians and patients can together make decisions about new drug therapy that might help reduce the risk of that particular disease.
Heart disease continues to be the #1 killer in the United States. Because of that, billions of dollars are spent every year on medications that reduce your risk of disease and death. Compounding this problem, many of the risk factors for heart disease seemed baked into the cake. Genetic factors can have a huge impact on people's risk, and those factors are almost always outside of one's control. Because of this, there are some who feel a certain amount of powerlessness to prevent heart disease. Recent research contradicts this, though, and should give all of us renewed hope. That's the topic of this week's Healthcare Triage. Since the 1930s, we've recognized that heart disease runs in families. For the last decade, we've been able to identify specific genes that are linked to coronary artery disease. In fact, these risk alleles seem to have a cumulative effect. Those who have more of them are at greater risk. Familial factors are some of the strongest arguments for using drugs like statins widely. After all, there's only so much you can do about your cholesterol through diet and exercise changes. Some people can only see reductions in cholesterol through pharmacological intervention. But still, it feels like we tend to treat those at low risk with lifestyle changes, while those at high risk get more intensive therapy. A new study in the New England Journal of Medicine argues that thinking may be wrong. Researchers gathered data from 4 large prospective cohort studies. The first began enrolling patients in 1987 and the last in 2008. All followed thousands of people for years, looking at the relationships between various risk factors and heart disease. Even though specific genes of interest weren't known when these studies began, data were available that allowed scientists to evaluate their genetic risk decades later. Using about 50 different single nucleotide polymorphisms, otherwise known as SNPs, they created a risk score by counting the number of risky alleles each participant had and multiplying that by an effect size derived from other studies. They also looked at how lifestyle factors were associated with outcomes. These included 1. Not currently smoking cigarettes, 2. Not being obese or a BMI less than 30, 3. Physical activity at least once a week, and 4. A healthy diet pattern. That last criterion was defined as doing at least half of the following recommendations: eating more fruits, nuts, vegetables, whole grains, fish, and dairy products, and eating less refined grains, processed meats, unprocessed red meats, sugar-sweetened beverages, trans fats, and sodium. Every single one of the 4 lifestyle factors was associated with a decreased risk of coronary events. That's the first bit of good news. Doing any of these things makes a difference. The effect is cumulative, though. The researchers divided people into 3 groups based on their factors. Favorable required at least 3 of the 4 factors. Intermediate required 2 of them, and unfavorable required 1 or none. Across all studies, those with an unfavorable lifestyle had a risk that was 71 to 121% higher than those with a favorable lifestyle. Even more impressive was the reduction in coronary events in every level of genetic risk. Those with a favorable lifestyle compared to those with an unfavorable lifestyle had a 45% reduction in coronary events among those at low genetic risk, a 47% reduction among those with intermediate genetic risk, and a 46% reduction among those at high genetic risk. In real-world numbers, among those at high genetic risk in the oldest cohort study, 10.7% could expect to have a coronary event over a 10-year period if they had an unfavorable lifestyle. That number was reduced to 5.1% if they had a favorable lifestyle. Among those at low genetic risk, the 10-year event rate was 5.8% with an unfavorable lifestyle, but 3.1% with a favorable lifestyle. In the other cohort studies, similar relative reductions were seen. These differences aren't small. The relative reductions were about 50%, meaning that the risk of a coronary event in 10 years was halved, but the absolute reduction, more than 5% in the high genetic risk group, means that if this were a randomized controlled trial, the number needed to treat would be less than 20 to prevent 1 coronary event. That makes lifestyle changes as powerful as, if not more powerful than, many drugs we recommend and pay billions of dollars for all the time. There are caveats, of course. All of the participants in these analyses were white because there are few well-validated genetic loci in black populations. The researchers also saw similar findings in the black population of the oldest cohort, though. These aren't randomized controlled trials, and there could be other factors at play that we aren't measuring. But the dose-response factor here is reassuring. The results were consistent over a number of studies as well, and the effect size is large. There are lessons to be learned here. These results should encourage us that genetics do not play an all-encompassing role in health. Changes in lifestyle can overcome much of the risk our DNA imposes. Those at high genetic risk with a favorable lifestyle had fewer coronary events than those at low genetic risk with an unfavorable lifestyle. Lifestyle changes may also be hugely important, not only for those at low risk, but also for those at high risk. The relative reductions in events were similar at all levels of genetic risk. Moreover, given how changes in lifestyle will also reduce your risk of other diseases like cancer, the number 2 killer, it's clear that encouraging a healthier lifestyle could have massive implications for many, many people. It's important to acknowledge that these lifestyle recommendations are even less constrictive than those I've discussed in previous episodes. You only need to be a current non-smoker. Past smoking didn't exclude you. You can also be overweight, just not obese. And unlike most physical activity recommendations, even those we've talked about before, this study only required once a week exercise, not the 30 minutes for 5 days that most bodies endorse. We seem willing to spend an enormous amount of money on technological and pharmaceutical interventions that often have a low, sometimes even questionable benefit. They also often come with significant side effects. Improving lifestyle could be safer and achieve much larger gains than many other things we pay much more for right now. Healthcare Triage is supported in part by viewers like you through patreon.com.